finished another webinar, so my voice is a little hoarse. So I am Kathy Pratt. I'm the director of the Indiana Resource Center for Autism and also the Indiana School Mental Health Initiative. And I'm also a board certified behavior analyst, so you're going to see things through the lens of behavior as we go through this webinar. If you have any questions about anything that I say today, I know it's really hard because you're going to be seeing this at a later date. If you have any questions, my email address is here, and I would encourage you to email me. If you don't understand something, please email me and I'll try to clarify. I know that I'm not always 100% perfect with explaining things to a group of folks who are bringing their own concerns to the table. So I'm happy to explain stuff after the webinar. I would also encourage you, I'm blessed with an incredible staff who writes wonderful articles and does great work. And so visit our website and our Facebook, Twitter, Pinterest, we've got it all going on. So just to tell you a little bit about myself, although I work at a university, I'm oftentimes in schools. I was a teacher for many years, and I spent a lot of time in schools, either helping them with behavioral concerns or helping them in implementing evidence-based practice, coaching them with implementing evidence-based practices. So this is going to be a little bit about my journey through all of this, how I got to the place of looking at those children who have co-occurring mental health issues, and hope it helps you guys out. So one of the realities I've been in the field for 40 plus years, and one of the realities that I was dealing with in the field of autism, I run a statewide program, is that we have an increasing incidence. And it seems like every year that we collect child count data, that the incidence continues to increase. And when I first started out decades ago, it was 1 in 10,000, and we're up to now 159 now individuals. So regardless what causes it or what is happening, we are seeing more kids, and I believe that the increase is real. The Indiana Resource Center for Autism, we really don't focus so much on why an increase is happening. We really focus on providing services for individuals. The other thing that I was seeing as I've been spending time in schools is that we have more and more children who are coming to us with other things going on, with more complex issues. So probably the record was I saw a student who had 14 different diagnostic labels, including ASD, ADHD, anxiety disorder, obsessive compulsive disorder, oppositional defiant disorder, bipolar disorder, and a host of others. And I had to question how a child got that many labels. And what happened is the psychiatrist told me is that every time mom would come in, she would tell more stories about her child, and then the result would be another diagnostic label was put on. So whether it was accurate or not, regardless, I'm seeing more children who have co-occurring mental health and autism in our schools. The other thing that I'm seeing in our schools are kids who are coming to us with increasingly complicated lives. We have more children living in poverty. We have more children who are being raised by grandparents. We have more children who have parents who are in jail or who have drug issues. We have more children who are living with trauma in their lives. So in the world of autism, more kids with more complex issues, living more complicated lives, we knew that there's not going to be simple answers. And I think, some of the strategies that we used with kids for years, simply for some of these kids was just not working. So we had administrators in schools telling us that they kind of felt like they understood how to work with kids with autism, but they were at a loss when those kids came to them with mental health issues as well. So we know that there is a percentage, and as high as possibly 70% experience a co-occurring mental health issue. The big one for our kids is anxiety, and with anxiety goes depression oftentimes. So and I've heard statistics anywhere from 40 to 70%. So we know that this is a real issue. And as I talk to my colleagues in other states, they're grappling with the same issues around how to address the needs of kids with this co-occurring disability. So we see kids who have a dual diagnosis. And in truth, if somebody has a cognitive disability and mental retardation, that is a dual diagnosis. By its very nature, individuals on the spectrum don't necessarily have mental retardation. And we have individuals, and we'll talk about all across the IQ spectrum. We have students who have learning disabilities, ADHD, obsessive compulsive disorder. Sometimes people will say that they don't think that kids with autism can have another diagnosis of obsessive compulsive disorder because by the nature they are obsessive. But I do see kids that have an extreme degree of obsessive compulsive behaviors that really go beyond what's expected of kids on the spectrum. So there was one child that I was working with who he would walk back and forth to a garbage can up to 40 times to throw something away and pulling it out of the garbage can, throwing it away again. Again, anxiety disorders are major for our folks. I see folks on the spectrum who have Tourette's, Fragile X, Down syndrome, cerebral palsy. If you go to our schools for kids with hearing impairments and visual impairments, what you will see is an increasing population of students who also have an autism spectrum diagnosis. So in many ways, they have a dual diagnosis. Epilepsy happens with our folks, and they can develop epilepsy into their 20s. And for some, it's grand mal seizures. And for others, it's more of the pettimolar absence seizures. Hyperlexia just means precocious reading early on without comprehension. Bipolar, impulse control. And we used to say in one of the previous versions of the DSM that an individual, if they had schizophrenia, that superseded a diagnosis of an autism spectrum disorder. And I think as I'm working with individuals on the spectrum and family members, you know, people are looking for answers. And I think I would go along with the idea that if an individual has bipolar or some other significant mental health issue, that oftentimes what we do in the field of autism is simply not going to be enough for them, and that we have to have more strategies in place. So with that, it's really critical to understand these individuals and how they relate to and understand their perspective of the world and how they best approach things. So I'm just going to do this really quickly, because how you interact with these kids around their mental health issues, you have to see it through the lens of autism and interact around the lens of autism. So you'll see the characteristics of these individuals that they fall all along the IQ spectrum. We have a population of individuals who have severe cognitive disabilities, all the way up to those who are highly intelligent, very gifted, and everything in between. And then we have at the extreme of that, some individuals who have special skills or savant skills, exceptional areas of intelligence. So, or they may play the piano perfectly or something. Social difficulties, and social difficulties can range from individuals who prefer to be alone. And I think that's the stereotype of our folks on the spectrum, is that they prefer to be alone. I have a friend on the spectrum who says that in a perfect world, she would like to have 2 friends, and that's so that they could take care of each other when she was busy, or she could have somebody around if she needed it. So, and then we have individuals who really want to have relationships, kids who want to have friends, or they want to date, or they want to have good friends. And it becomes very difficult for them to not only obtain those relationships, but also to maintain those relationships over time. And then you'll see expressive and receptive communication difficulties. So for our individuals on the spectrum, if you're giving instructions to a whole class, they have a hard time understanding that those instructions apply to them also. And they may process information at a slower pace than others. I know I have friends who it takes them 15 seconds to process a question. And then at that time, people are asking them the question over and over again, and it just frustrates them. And then expressive communication, we have individuals who are nonverbal, and they will use their behavior to communicate. And then we have individuals who are highly verbal, but they lack the ability to tell us what they're really thinking and feeling in situations. And then we have individuals who have echolalia. And echolalia is either immediate or delayed echolalia. Immediate echolalia is I say something to you and you say it right back to me. Delayed echolalia is that I'm asked a question or I'm in a situation and I pull from conversation that I've heard before, either in movies or in videos or in other conversations. And the difficulty is that when our kids are allowed to watch things that have violence in them, sometimes that they will use some of that violent communication. And I've had kids who will say things to staff like, I'm going to chop your head off. And so I really tell parents, be careful what your child watches, because they may mimic that and use that information for later. We also say that individuals have a restricted repertoire of interests and activities. So our folks become intensely focused and intensely interested in certain topics, certain activities. You know, I have friends who have interest in the weather, in movie credits, in ceiling fans, in vacuum cleaners, and I'm sure all of you have worked with children who have interest in a whole host of things. Obviously, video games is a big one for our kids, both on and off the spectrum. And for our folks on the spectrum, they refer to them as fascinations. We sometimes refer to them as fixations, but they do develop that restricted repertoire. And what's good is that if you understand what those interests are, those fascinations are, it's a great way to think about building those into programming, and also about how to build a rapport with the child by talking to them about some of those interests, capitalize on those interests. And by the way, people on the spectrum think that don't understand us at times. They refer to us as NTs or neurotypicals, and they don't understand how we process or interpret or understand the world. And so understand at the heart of it is that autism is a neurological disorder. And so if you've ever been around anybody who has a neurological disorder like dementia or a traumatic brain injury, you'll understand what I mean when I say that there's just something different about the essence of them and how they understand the world. You'll also see that our folks have weak central coherence. So these are individuals who, if they came into my office right now, and if 5 of us were sitting around my computer with social distancing, they would be oblivious to the fact that all 5 of us were focused on the computer, and they maybe would want to play with the computer or do something with the computer or focus on something else in my office. So they become fixated on an aspect and don't take in the whole big picture of things. You also see some additional considerations, again, seizures that our individuals develop, medications. I'm not a doctor, so I'm not going to talk about medications. I really believe in staying in my own lane, and medications are not my lane. What I will tell you is that if an individual is being medicated, we should be very clear why. What is the purpose of the medication? Because sometimes I will see children receive medications and it's not the issues that they're dealing with. We also see that some children have gastrointestinal issues or other health issues. And so when I talk about behavior, I'll talk about some of those issues as well. Some of our folks have pica, which means that they eat inedible things. And then some individuals have behavior difficulties. And the behavior difficulties are probably those things that challenge us the most, problematic behavior. And just so you know, I'm a board certified behavior analyst. And so when I talk about behavior, I have a very broad definition of behavior. I think about behavior as anything that we're doing. I'm sitting right now, and that's a behavior. I'm talking right now, and that's a behavior. And so some behaviors are problematic and others are not. So as I've been getting involved in this field of mental health, I became familiar with the ACEs study and the ACE questionnaire. I'm sure that you can easily find it on our website. There's a lot of work being done around that, and a movie that was out called Resilience. And what's interesting is that they have found through research that when individuals have experienced so many different life situations, that it has an adverse effect on their stress and also on their physical health as well. And so it's interesting to look at the ACEs questionnaire just to see the questions and get a sense of the possible things that our individuals could be experiencing in their life. And so we also know that if an individual has an autism spectrum disorder or any kind of disability, and I hear this a lot from my women friends on the spectrum, is that they have a higher chance of neglect, physical abuse, and sexual abuse. For women on the spectrum, the physical and sexual abuse, because they oftentimes don't read the intentions of perpetrators. So that becomes a challenge for them. So common characteristics, and I think one of the things that is interesting to me is that people on the spectrum who have mental health issues, who live in tough situations, oftentimes what I would consider to be chaotic situations, they actually may find comfort by being in those chaotic situations. That's what they understand. But individuals who live in those kind of situations develop some skills. I was reading a book by Brene Brown recently called Daring Leadership and Daring to Lead, Daring to Lead. And one of the paragraphs in the book talks about that if we are in a situation in life where we're always walking on eggshells, never knowing how people are going to respond, how that can create trauma with us. And I think for our individuals who live in tough situations, in situations that are stressful, they probably always are walking on eggshells. Another analogy that I hear is that, when we talk about individuals who are dealing with stress and trauma, is that if you think about it and we're walking through the woods and we run upon a bear, we have a fright response. For some of our folks on the spectrum, they are always in that stress response. They're always facing that bear. So some of the characteristics are that some individuals learn to be compliant and passive just to deal with the situation that they're living in. They may be threatened or coerced by the withholding of needed care. So they're afraid of losing the support they have, even though it may not be fabulous support, they're afraid of losing that support. I also see that some of our folks will socially isolate. I've been talking to a couple of adults recently who have been socially isolating, not related to the pandemic, but just related to the trauma in their life, that they have removed themselves and not dealing with things. And then we also know that, when folks rely upon others for assistance with intimate issues, that we have to be careful that they're not taken advantage of. One of the hard things that I do is that sometimes I will be involved in court cases and with individuals who have been sexually abused by people in group homes or other situations. So realize that our folks are really major targets for being victimized. And they may be hesitant to leave that abusive situation because they don't know anything else and they may not have other options available to them as well. So we have to understand the potential for and role of trauma. And again, the ACEs study, looking at the video resilience, looking at some of the work that's been done around the ACEs study is pretty powerful. But realize also the natural role of stress created by the disability itself. I've been reading this book called Self-Reg by a man named Stuart Shankar. And it's really a wonderful book. And he talks about some of these stressors. And for our individuals on the spectrum, we know that the stressors can be related to sensory stress, the stressor of demands, stressors related to various characteristics of ASD. And we also know that the stress can be caused by bullying. Our folks sometimes don't understand the difference between being bullied and teased, and that may need to be explained to them. It could be from previous experiences that they've had in life. It could be from the behavior approaches that were used in the past. If timeout or restraint has been used with the child, those may be causing stress and trauma for kids. Staff, professional, family interactions. I know when I go into schools, and generally I am working with people who really want the very best for kids, but every once in a while I'll be around somebody who is in front of the child to say negative things. That child hears that, whether they can communicate or not, they hear that. And then there's events in the community, treatment by people in the community, whether it's in transportation or it's on the playground. There's things that can create stress and trauma for our kids as well. So you have to see it through the lens of the individual. You have to understand it from the person's perspective, through the lens of somebody on the autism spectrum, which is different than our lenses, how they interpret all of this. We have to understand it. And even though it may not be our lens, we have to validate it and acknowledge that it is their lens and listen to them. And what we know is that when individuals are in constant stress, that it raises cortisol levels. And when cortisol levels are raised, it changes our neurology. It also can impact our physical health, and it will also make rational thinking much more difficult, and reactivity becomes much more prevalent. In our state of Indiana, we have a colleague of mine at another university who has been doing some really wonderful work around neuroscience and behavior, Lori Desautels. And her books are fabulous, and she's just really brilliant and has really kind of helped to shift the thinking of a lot of our schools in Indiana. It's been amazing and remarkable. So when individuals have trauma events in their life, realize that some will exhibit those trauma events outwardly and others become introverted and depressed. There is not one response. And again, I want to keep hitting on this fact that anxiety is going to be major for our individuals. I want to talk about resilience up front. I'm going to talk about resilience a couple times. And this may be something where you need clarification, that I may not explain it really well. So what I see as individuals are working with children on the spectrum, and I hear this in conversation a lot. I was just on a phone call with some advocates, And what I see is that we kind of have this continuum where some folks feel that it is their job to get the person to respond like everybody else, and to assimilate, to be like everybody else, to be, as we call it, normal. And one individual on the spectrum said that he didn't know what normal was, but he thought it was the second button on a washing machine. So there are those folks that just expect these kids to be like everybody else, which they're not going to be. You know, they're always going to have an autism spectrum diagnosis. They may improve, but there's always going to be some challenges in some areas, but all of us have challenges. And then on the other hand are those individuals who they feel that our job is to just accept their autism and to accommodate them in every way, just to accommodate the fact that they have autism. And so those are individuals who, feel like their children need to be at more autism specific programs, that family members who, and families have to choose battles. I'm absolutely not making judgments on this, but if, the child doesn't like the TV program they're watching, they change. If they don't like the activity the family's involved in, the family leaves. If they don't like what mother has cooked, mom cooks something else. So always accommodating. So what I tell parents is that with our individuals, we have to kind of push a little bit, just to the edge a little bit, and have a safety net underneath them and support them. But if we never let them fail, if we never put them in situations where they have to stretch themselves, we're not teaching resilience. And as an educator, I have to look at, as a teacher, I always thought about what would happen to my students when they were 25? Where will they be when they're 25? And really clearly in the literature, it talks about the importance of resilience. And I know for some people that makes them feel uncomfortable, but I think that we really have to learn resilience. And so for some of our kids, that they have to learn that they're not always going to win or come in first place or be first in line. Really learning how to deal with failure is a really important thing for all of us to learn. So as all these realities started to change my paradigm about behavior, we talk about behavior now as stress behavior. And again, I have a very broad definition of behavior as I'm looking at these kids. So if behavior is an issue, if how they are manifesting their issues are through behavior, their mental health issues or their ASD issues is through a behavior, remember that behaviors are just symptoms of larger issues and underlying conditions. So, I will get phone calls saying, I have a student who does this, what do I do? And I'm going to talk a little bit about the crisis response, but I don't know what's going on. I'm somebody who has to get to know kids. And I think about this like in terms of a medical diagnosis. I've inherited a 92-year-old Greek mother who 10 years ago started losing weight, started having chronic headaches and diarrhea and other symptoms. Went to one doctor and said, we are going to give you medicine for your headache. Another doctor said, you need to start drinking. And sure, another doctor said, we're going to give you this medication for your bowel movements, for your diarrhea. And finally went to a doctor who said, we need to find out what's going on. Found out that she had lymphoma that was all contained in her spleen. When her spleen was removed, it threw her into remission. And so she has now experienced the marriage of two and soon to be three granddaughters, and the birth of 4 great-grandchildren, and she's doing really well. So when I look at behavior, I think about the fact that too often we treat the symptoms and we don't treat the underlying reasons. So we really don't treat the behavior of hitting, kicking. We treat what's leading up to that behavior, what's causing that behavior, what's motivating that behavior over time. And I'll talk about that a little bit more. But if you are in crisis, and hopefully, if you have children who are in danger of hurting yourself or hurting other staff or hurting themselves, that there is some kind of a plan in place. I'm not really going to talk about crisis planning, but just to tell you that, I think about it in terms of a de-escalation plan, that our job should be to minimize the situation. And so with this, we minimize verbal comments and with kids, don't talk at kids a lot when they're upset. The quieter we are, the better it is. I think, I know that as I interact with kids who have behavior difficulties, I try to stay really calm. Sometimes folks think that I'm barely breathing because I stay so calm. And I have to tell you, I just honestly go to a happy place in my head. And it's not that I'm not taking the behavior seriously, but I know that as soon as I show an emotional reaction, I'm now at danger of escalating the behavior. You know, don't approach quickly, don't lay your hands on. Really, the goal is to de-escalate the child and understand the escalation cycle for them, understand the indicators that tell us that they're starting to escalate and catch the behavior before it gets out of control. Realize that our reactions may strengthen the behavior, so really be aware of how we react. You know, behavior is a dance, and we're part of that dance. And so we have to think about how we engage in that dance in a way that doesn't intensify the behaviors. Avoid power struggles. When people say to me, I'm going to win and this child's going to lose, believe me, you're going to lose a lot of times too. This is not a power struggle. This is about how everybody comes out a winner. And then I always focus on self-management and not control, because I'm not going to be in a child's life for the whole life. I want them to develop some skills that they can deal with. And I've worked with individuals who have very significant challenges and very cognitively disabled, to all the way through those individuals who are very bright. And with all of them, I've worked on self-management or emotional regulation. Interestingly, as I've gotten into the field of working around kids with mental health issues and tried to learn about the mental health literature, I've been in multiple conferences where the folks who are dealing with kind of in the field of mental health are talking to me about zones of regulation and the incredible 5-point scale, both of which come out of the autism community. So hopefully you have some tools around that. And again, there's not going to be a recipe, but there's just some tools that may help out. And I know in our state, I don't live in a fantasy world, that despite our best efforts, we have some kids who need medication. And despite our best efforts, we have some kids who need either short or long-term hospitalization. But if there is hospitalization and the child will be leaving that clinical setting and coming back into school, there should be a reentry plan, a transition plan developed. Because what we know is that if individuals go into a clinical program or clinical setting, and then they come back out and they're placed right back into the setting they were in before, those behaviors will return as well. So there has to be some thought to preparing the setting that they're going back into. So here's the incredible 5-point scale. We use this for a lot of different things. And again, our visual supports are on our website for free. You can download these. But we have used these, and this was used with a young man who had a lot of different diagnoses that included both ASD and things in the mental health area. He was very bright. He was very high on the spectrum. He had a tendency towards some pretty aggressive behaviors. He could clear a classroom pretty quickly. And so the school was working with him. And so I don't want you to think that this is all we did. There were a lot of things that we did, including more support for the family, getting him hospitalized for a short period of time because he had lost his psychiatrist, and his doctor had pulled him off of all of his medication, which meant that he had an even more violent event in his life. And there were a lot of things, coaching around staff and stuff. But one of the things that we did was thinking about the importance of teaching him to do some self-management, is that we did the incredible 5-point scale. And I've done this with other kids as well who don't have an autism spectrum diagnosis. So for him, and I don't remember what all the numbers were, but we developed this with him. One was, I'm calm and I can do the work, and I can stay in the classroom. And if he moved the paperclip up to 3, that meant I'm anxious. And we had rehearsed with him ahead of time what he needed to do when he was upset, when he got upset, when he could identify the signs of being upset. And we talked to him about those indicators of being upset. Because what we know is that the best time to interact around behavior is when the behavior is not happening. So when he got to 3, he had made the decision that he would like to do one of 2 things: either walk down the hallway and talk to somebody, not be lectured to, but talk at somebody and process, or go someplace where he could do something physical, like jump on a little trampoline. And then if the paperclip went up to 5, we knew that it was probably time to clear the classroom because he was escalating. And over time, it was amazing to see him use this. And the key thing is that we had to make sure that staff were consistent, and they followed his lead on this, that they acknowledged and appreciated and honored his responses. So the first thing we want to do is to operationally define the behavior and identify all behaviors of concern. I usually like to know everything that's going on, because we talk about behaviors in terms of a response class. And when I'm looking at those behaviors, I want to remove all judgment. You know, people will say, well, this child just does this behavior to get out of doing work. And that could be true, but I don't know if that is true. You know, I have to look at the data and see the justification for that decision. And so, you know, there's judgmental terms that we use like non-compliant. I'm not really sure what that looks like. You know, does that say that the child says no when given a direction? Angry, you know, when I'm angry, I have a tendency to get quiet. Some people get verbal, you know, other people throw things. So we need to know what the behavior looks like and consistently across folks that are interacting with the individual, reach consensus about what that behavior looks like. And that's especially important when we're looking at data collection because we have to be consistent in our data collection. And I really believe that the more objective we are, the easier it's going to get to the heart of the issue. The judgments just kind of cloud things up and muddy the waters a little bit for our folks. So when we look at antecedents, we look at two different kinds of antecedents with individuals. And in behavior, we look at behavior as what comes before and what comes after the antecedent, the behavior, and the consequence. So in antecedents, there's two different kinds of antecedents, the slow triggers and the fast triggers. And I think this is really a call that we have to look at the entire individual and their whole life. And I think that the setting events are actually probably the most important antecedents that we need to look at. They may happen anywhere. They increase the likelihood that behavior will occur. So, you know, I'm doing this webinar for you all in the midst of a pandemic. And so my technology is on and off working okay. I got up this morning and had a little difficulty getting on. And so I know with my first webinar for the first few minutes, I was struggling a little bit to kind of regroup. So these are things that, you know, you have a bad morning, you have a fight with your spouse or your children, or the clothes you want to wear are at the dry cleaners. And whatever it is, these are things that kind of make you less able to cope with situations. So for our kids, this could be anxiety or biological issues. I was working with a young man and he was doing really well. And then all of a sudden his behavior started to tank. And so the response was, we've got to tighten up the behavior plan. Well, as I looked at him, I could see that his jaw was bruised. And so we got in his mouth, which was not easy, and looked, and his teeth in the back were rotted. And I can't tell you the number of situations that we've been in with kids that when we've dug deep, we found that there's some kind of a medical condition or biological issue going on. You always want to rule that out first with our kids. Again, understand that trauma and their neurology is a setting event. Schedule changes. You know, I can't imagine how things are for these kids now and for their families because their life has been rocked. You know, some kids are doing better. I hear overall, I think some parents and children are struggling, but the schedule changes. And, you know, as we face the potential of what the fall may or may not bring, that's going to be hard. And we're going to have to think about how kids re-enter into the school environment. We also, staff changes. I know in our schools, sometimes there's a turnover of paraprofessionals, and finding full-time licensed teachers is sometimes difficult in certain areas, but the more staff turnover there is, in the adult services or in residential programs, we see a high turnover of direct service providers. Medications that are changed or missed. And I know as a teacher, sometimes I would have parents who would choose not to give their child medication over the weekend. And the medication was cumulative. So when the child came back on Monday, and even though they had their medication that day, the medication didn't kick in until a couple days later. Irregular sleep patterns, and we know that sleep is really important. As a teacher, I would have students who would act out and then a couple days later would have an illness. Missed meals can be a setting event. You know, kids are hungry. And sometimes kids are hungry at different times of the day. And so expecting them to eat, you know, sometimes giving kids a snack will be a great thing to deal with the behavior. Arguments or fights with classmates, parents, teachers, spouses, obviously not for your students, but, you know, for you all, those can be setting events. And the one that I really want you to highlight is this whole issue around skill deficits. Skill deficits are a setting event for folks. And I really look to the work of Ross Greene, who is brilliant. And Ross Greene has an adage of that if they knew better, they would do better. So at the heart of behavior, we always talk about skill deficit. And one of the things that we're working on right now in Indiana is to help our teachers think about how they write behavioral IEP goals that focus on what children will learn and not on what they will stop doing. Home conditions can have an impact, and that does not mean that, you know, parents are not dealing with their child well, although that could happen. You know, these kids don't come with a manual, and parents will struggle. You know, kids are very different at home than they may be at school. But this is also talking about, you know, we're going to have a very high unemployment rate. We have people who are living in poverty. We have individuals who are going through marital stress. We have individuals or households that are going through loss. We have an article on our website about loss for children who are dealing with divorce or the death of a family member. Those are things that are going to impact kids. I know as a teacher, I had a student who was invited to join my classroom, and those of you who are teachers out there, you know what that means. It means that the teacher that she had didn't want her anymore, and so the student was invited to join my classroom, and her behavior had just tanked. And when I called her mom to just get some insight, her mom said, well, you know, nobody called to ask me that, you know, to find out that I have another daughter at home who is dying from brain cancer. Well, of course she was responding to that. And past and current experiences can have an impact on students. Then we look at fast triggers, and these are things that we know that if this happens, that there's likely to be a behavior that occurs. And those can be things like kids being teased or bullied or feeling socially isolated. It can be a specific type of task or activity. We know, for example, that paper and pencil activities are difficult for our kids. Certain noises, fire drills, sometimes those noises are undetectable to us. The example that I gave in this morning's webinar was about a parent who came up to me at a conference and said, my child has a hard time going to the grocery store, and I don't understand why, especially when going through the checkout stand. And unfortunately, I was standing there with a friend of mine who is on the spectrum who said, you know, when people scan food, you don't hear it, but it gives off a really high beep. And so the person was hearing that. Too much programming or too little unstructured time. I think that kids need a little bit of downtime. And so I worry when kids are like in constant programming. But on the other hand, I think when kids are not given something to do, they will come up with something to do, and it probably won't be so delightful. Transitions or changes will be a trigger for kids. Certain people may be a trigger, a certain request may be triggers for children. So these are things that you know, if this happens, that the behavior is likely to occur, and so we can plan for it. So consequences, and I want to explain this from an ABA perspective, behavioral perspective. So from a behavioral perspective, the only definition of consequence is that it comes after a behavior, antecedent behavior consequence. And so a consequence follows a behavior or response. It can be a reinforcement. And by that I mean that a person gets something. How it's usually thought of is that somebody gets something, but the true definition of reinforcement is it's an event that occurs that increases the likelihood that that behavior will happen again. Okay? Punishment is usually we think about it in terms of taking away things, although it's not always. So punishment is an event or an activity or something that will have a tendency to decrease the behavior. So you have to understand this individually. So if a child doesn't like chocolate, which I don't understand that, but if a child doesn't like chocolate, then they may not find chocolate to be reinforcing, it may be punishment. On the other hand, I know that I have interacted with kids for whom suspension and expulsion is a reinforcer. They're in school, they're not feeling successful, so they're sent home and they get to play video games or they get to go shopping with mom. So being home becomes much more reinforcing for them than being in school. So consequence really asks the question is, what is motivating this behavior? What is the payoff? Why does the child keep doing this behavior? What is maintaining this behavior? Why are they doing this behavior over and over again? So I use a lot of different tools and not always all these tools at once, but these are kind of things that are in the back of my head in terms of the questions that I ask. I'm going to give you some of the questions, but I look at various informal or structured interviews with multiple questions. We do rating scales or behavior checklists. There's a lot of standardized things and just behavioral checklists out there. Sometimes we'll do a learning styles inventory to see how a child learns. I want to look at a comprehensive evaluation to see really where the child is functioning, because I've been in situations with kids who've been having behaviors because the curriculum is really not at a level that is appropriate for them. It's either too complicated or too easy for them. So I want to understand really where they are in terms of their comprehension. I don't use the ACE questionnaire as a screening tool for behavior, but I think it's just a tool of awareness for teachers to look at, to realize that some of these kids come to us with all kinds of stuff, all kinds of things going on. And then the lagging skills inventory from Ross Green. This is the website for that. I would look up Lives in the Balance, which is the Ross Green website. And he has a lagging skills inventory that gets us looking at what are the skill deficits of individuals. But always within the setting events, you have to identify the skill deficits because that's going to really become what that's going to be what you focus on in terms of teaching new skills. And then I love the Ziggurat, which was developed by Barry Grossman and Ruth Aspey, and especially the Ziggurat Strengths and Skills Inventory. And I will give this to people to fill out. And what's lovely is that we start identifying those things or those areas where the child does well. If I can understand the strengths and skills of the individual, that really helps me in developing a program. And I think it really is a good way to kind of build a relationship with a family, is to kind of turn the conversation away from deficits to a discussion about strengths and what the individual can do well. And then record reviews, and I will look at the records and I'll talk about that a little bit more. So some of the questions that I ask are around, what's the history of the behavior? When did it first happen? Has it persisted? Has it improved or deteriorated? What's been used in the past? What worked? What didn't work? Just giving a sense of how we got to this place with this individual. And I know I've worked with, as a teacher, I taught children from the ages of 3 through 21. And especially when I was working with the older folks, I thought if only we had gotten to this earlier. And so for me to understand a little bit about the history of how we got to a place was oftentimes very helpful for us. So some of the questions that I find incredibly important are related to strengths. Tell me those conditions under which the individual is doing best. When I go in to see, and my staff go in to see individuals with behavior challenges, sometimes when we go in, the person is having a perfect day. And I know staff is really upset because they want us to see the behavior. Well, I know what it looks like for a child to hit and kick and all that kind of stuff. But for me, seeing those things that are helping that child be successful is actually more beneficial, because if I can identify what helps an individual be successful, then I can talk about what we can replicate to make that child successful during more times of the day. What are their areas of strength and interest? Have we really built upon those? Are we using those for reinforcement? And does every person, every student that we touch have the opportunity to be successful each day? And that to me is really critical, and we'll talk about that. I also look at what setting, does the behavior happen in? And what are the aspects of that environment? Is it related to space, noise? Do we have too many kids in one small space? Is there an organization of the space? Is it lighting? What is exactly kind of the aspects of the environment that are creating this behavior problem? I will actually look at the schedule, and I will count the number of minutes in the schedule, and I will count the number of minutes that the student is not involved in anything. And the standard is that 80% of the time students should be engaged. And that doesn't mean that they're sitting at a desk doing one-on-one. We can engage kids during lunch and during break time, anytime, just being present with them and engaging with them and using those as teachable moments of helping kids learn things and generalize skills. And when I go into situations, and I have been in situations where I've seen kids only engage 20% of the time, what I will see is more problematic behaviors, because again, if we don't give kids something to do, they will come up with something. Are there certain times of the day that are less or more problematic for the child? And, so if we find that there's a time during the day that we know that this child is always having a good time, that may be a really good time to focus on teaching them that alternative behavior, that alternative skill, because again, we teach those when behaviors are not happening. Are there specific activities or courses and there specific staff? And what are the characteristics of those staff members who are most successful with the individual? And then again, going back to what are the skills? Do people really have the ability to respond in an appropriate fashion? Just expecting that they will do it or telling them to do that does not mean that they have it. And so things are going to have to be very proactively and intentionally taught to them. We also look to see if the behavior serves a purpose for the individual. And we oftentimes use the motivation assessment scale as one of the tools to do that. And what we know about individuals is that they often engage in behavior to either get something or to escape something. But we also see with some of our folks that behavior is really driven by sensory issues. And when I was a teacher, I had a student who engaged in self-injurious behavior. And we were able to determine, he was nonverbal, but just kind of by getting to know him a little bit, we were able to determine that the self-injurious behavior that doesn't make sense to me, that to me would seem to be very hurtful, for him actually gave him deep pressure and was pleasurable. We also look to see what is the individual's primary means of communication. And again, there's a tight link between communication and behavior. So can that person communicate, and how do they communicate? And does the individual need an alternative communication system? Oftentimes when I get called in to see an individual, their ability to communicate is really lagging, whether they are highly verbal or not. I mean, if communication was so easy, we wouldn't need all these talk shows like Dr. Phil. Communication is just difficult. So how do they communicate? Do they need a communication device? And this is really important. And there's actually some literature that talks about that when kids have AAC devices, by the time they hit secondary programming, I think the statistic is something like about only 15% of them are still using their augmentative systems. And then by the time they hit adult services, only about 15% of that 15% are still using them. So it's really important to think about building in communication systems that are going to be lifespan for our folks. Does the first person have any medical problems or take any medications? Some medications can have an effect that's not positive. We do have some individuals who are self-medicating with marijuana and other things, and then we have to get kind of addiction people or other people involved in that. There is not an autism approach to substance abuse that I know of, but we have to really think about how we help individuals deal with those abuse issues. And then does the individual have difficulty with sleep or with eating? What is their diet like? Is it healthy? I also look to see what a person's quality of life is like. And there is research. And Ted Carr, who was an outstanding behaviorist, who is unfortunately long deceased, I remember I heard him speak at a conference one time, and he said he'd come to the realization that the happier people are, the better they behave. And what I've seen is that when people have improved quality of life, that their behavior really improves, And unfortunately, sometimes we make perfect behavior a prerequisite for doing things in community settings. And I have found that working with a lot of students with a lot of behavioral difficulties is that as I was able to enrich their life, slowly and with supports, enrich their life, that I saw behavior incidents decrease for them. Several years ago, I was called in with a colleague to do an assessment of a residential provider. And it was really eye-opening for me. This is a residential provider that was a group home. And they were getting people who had been institutionalized from birth. These are folks that were about my age that were institutionalized, the age of Oprah. So when I was born, parents were told if something was wrong with their child, put your child away and forget that they even exist. And so these were individuals, adults who were institutionalized early on. In the process of deinstitutionalization, they had moved them to a smaller congregate setting, and then they had moved them to a group home. In that congregate setting, not the group home, but in that congregate setting, there had been some abuse that had gone on. And so we were called in to look at the group home setting to make sure that they were receiving good services. And so I was reading the files of one of the men who, again, was my age, and he had a really thick file because he had a lot of extreme behaviors. And so I read his file, and then I went to meet him, and he was very, very sweet. He was nonverbal, but he was very sweet, very calm. And so I asked, what did you do with him? And they said, well, come into the garage, we'll show you. I was like, okay. So in the garage was a kiln, and they had found out that his special interest, that he was really good at making pottery. And so once they gave him that opportunity and got him involved in pottery classes, what they saw was a reduction in behavior. So that doesn't mean that behavior will always totally go away, but I think that if we can improve those quality of life indicators, and that was so dramatic to me, it was just amazing. I also, again, if there's conditions inside the home, we have to acknowledge those. And sometimes our folks are going to need help from outside agencies. I don't believe that school folks can do it all. I was a teacher. I don't know that we can do it all. Families will need financial resources, and they'll need social services, and they'll need medical help. They'll need various kinds of assistance from different agencies. And so in Indiana, we have this thing called systems of care. And the idea is to bring together our community mental health centers, our juvenile justice, our justice systems, our faith-based organizations, our educational systems, and to have a committee that talks about how agencies come together and work on behalf of individuals. And I'll talk a little bit more about that later on. But I think sometimes we just have to help families get connected to other agencies. And so in Indiana, when I do a behavior consult, oftentimes part of that behavior consult is getting families connected to other family organizations, or getting them connected to other financial resources or other sources of support. So then I review records and medical records, IEPs, IHPs, IPPs. I look at previous behavior support plans, and the number one reason why behavior support plans don't work is because they're not implemented. I look at psychological assessments and see what was done in the past, and how where the individual is cognitively. For me, the scores aren't as important as how they perform on individual tests, but then I'm not a diagnostician, so all of us have to find our own path. I want to know what's been done with them in the past. Something that we oftentimes spend time with is our anecdotal records. So people will write long journals about behaviors, and oftentimes those are less helpful because they really are a lot of judgment. So I always want to look at what the data is. So the next thing that we look at is we also may look for data, and direct methods for gathering information just means that you're looking at the child while you're collecting this information. And so I may collect data, and there's different ways of collecting data. There's all kinds of data forms out there. I personally love the scatter plot. It is just my go-to. It's worked for me. And I'll show you that in a second. But sometimes we collect data around frequency, sometimes duration, intensity of recording, and sometimes we do all three. There was a young man that I was working with who we collected data on frequency, duration, and intensity. And what was interesting for him was that the frequency of the behavior didn't go down, but the duration lessened and the intensity lessened, so that we could acknowledge that we had some good movement. So you want to have a mechanism and train people on how to take that data so that we can have some kind of objective information about what's going on with the individuals, and again, remove the judgment. This was about a young man who had co-occurring mental health and autism. It was with his 7th grade teachers, and he would curse, stare at peers, and make loud noises. This was a low frequency behavior, which meant that it didn't happen very often. So we keyed it that way. So if it was 1 time, we did a slash mark, 2 to 5 times an X, more than 5 times colored in the box. If it was a higher frequency, we would have increased it. We could also change the key to be a duration, so 0 to 10 minutes, and then we can add an intensity scale on it and use different colors to highlight different levels of intensity, and those could correspond with the incredible 5-point scale. So the scatter plot comes out with data like this. So obviously we want to go back and we want to put some definition on why is it that we're getting this data? What's going on? Like for me, I am less concerned. Well, I am concerned about what's going on when there's problematic situations occurring. But for me, why is it that science is so good? Because what I found is that a lot of times when students have 2 bad class periods, that it's really hard for them to regroup for the rest of the afternoon. So something had to be happening with that science class that kept that child engaged. So you want to kind of dig a little bit deeper and get a little bit more information, a little qualitative information about what's going on with this data. But this to me is just a really easy way of collecting information. I am not one to recommend that teachers collect data that's going to require a lot of time. So this is pretty easy, and I tell our educators to just use their best guess on it. So when you're assessing, make sure that you listen to the student, talk to the student. And even if they can't talk, listen to them. They will tell you what's going on through their behavior. I have never met a student, and I've worked with individuals. I worked with an individual who had a measure of IQ of 0, which I'm not really sure what that meant, but I think what it meant was that they had gone into the tested environment and gotten aggressive, and the assessment person gave them a 0 IQ, all the way up to individuals who have IQs of 160. And for every one of those individuals, they have been able to tell me something that is going on with their behavior, whether it was verbal or by just watching their actions, their facial expressions, whatever it is, I can tell. If you really listen to these kids, you can see what's going on to them. And I think make sure to listen to the parents and families. It is not unusual that kids will be different at home than they are at school. The demands are different at home than they are at school. So students may be better, they may be worse. We also see that some students hold it together all day at school and then they fall apart at home. So really listen to what the parents are saying, because they're going to see a different picture of their child, and they have learned some strategies that will help with their child as well. And then understand, as you're making recommendations to the families, understand the competing demands on their time. I think one of the things that I'm hearing from families right now through all of our distance learning and e-learning is that families are being really stressed by the demands on their time, that they may be trying to hold down a job and at the same time provide education to their children online. And it's placing a lot of stress on families. So we have to really be aware of the demands that are placed on families' times. And in those situations, know what you can or cannot control. If a child comes to school and you know that setting events for them if they don't eat breakfast, they don't sleep enough, they have fights with their siblings, you can't control all of those things. What you can control is that the child gets something to eat. So know what you can and cannot control, and then don't use those things for which you have no control over as an excuse to do nothing. There's a lot of things we can't control in life, and we have to know what we can control. You can control having your classroom be a safe environment for kids. You can control that children will feel successful with you. You can control the relationship you have with them. You can control giving them something to eat. There's a lot of things you can control as you interact with kids. But again, address the whole child. Look at them biologically, emotionally, academically, socially, and then think about the whole family and the impact. So this is a video, the way that I kind of organize information, and I'm going to make it a little bit bigger for me here. So we gather information. People sit around and they gather information, and I look at data. And so then I always want to think about, how do I put it into a format so that I can start logically linking program to it. So this is a young man who pinches, yells, screams, kicks, and hits. He has autism and anxiety. He takes medications. He has allergies. He has communication limitations. He's very verbal, but he still is not able to tell you what's bothering him. He has sensory challenges. He lacks self-management and regulation. He has poor social skills. He has frequent school changes. He's gone through about 3 different schools. He has previous experiences in schools that have been both positive and negative. He has some trauma in his life. He has a lot of home instability, and things are going on with his parents that, have made his life a little bit more difficult. And so, and then the triggering antecedents, these are things that we know that if they happen, that he will have a behavior. Certain demands, too much talking to him, transitions, leaving the school bus is difficult, changes in routines, certain academic work, too much paperwork and being read to or lectured to. What he gets out of his behavior is that when he gets his behavior, he gets to end the activity, which for him is very reinforcing. He gains access to a desired event or activity, and he gets attention from staff members who try to console him, from the staff member who doesn't like him so much. And then he has some sensory needs that are met at the same time. And then I want to look at what are the strengths and skills of individuals. So I think, a lot of what we could do again with kids are really going to be based on the relationships we form with parents. So I like to start with a conversation about, tell me something about your child's strengths and skills. Rote memorization, learns routines, shows interest in classmates, strong relationship with certain staff members. When interested, can focus on activity for extended periods of time and likes to help. So We know that these are good things. And I did this when I put this hypothesis behavior pathway together. I did this because I felt guilty when we would sit around and talk about behaviors and we kind of deteriorate into a conversation about how bad things are. And I think we really have to turn that conversation to more around some things that are a little bit more positive. So in the field of mental health, there is a strategy called cognitive behavior therapy or talk therapy. And I know that some of our community mental health centers and some of our professionals have found that to be less effective with folks. I'm sure it works with some. It may be less effective with other individuals. For our individuals who are very concrete and very rote, who have difficulties with both comprehension and they have difficulties with expressive and receptive communication, talk therapy may be more difficult. They may just tell you what they think you want to hear, which probably happens with a lot of folks. And so it may not always be the most effective things for our kids who are very literal. More and more we see in our community mental health centers that they are taking an approach of really dealing with skill deficits, of teaching children a different way of responding. Which is really a good fit for us in the autism community because that's the approach that we've taken. But in the autism community, there's always conversation about what are evidence-based practices. I will tell you my go-to for evidence-based practices is the National Professional Development Center on Autism Spectrum Disorders out of North Carolina, the National Professional Development Center on ASD. And they have a listing of evidence-based practices that they've just updated. And so we know that if we use those practices, that there's a likelihood that we can address the skills of our individuals. I think what I see is, when in the field of autism, when you take something that went from a disability that went from 1 in 10,000 to 1 in 59, 58, what we saw is that autism became a business. And there were lots of businesses out there that were not so great. And I see a little bit of that in the area of mental health as well. So I refer to places like the National Center on School Mental Health and CASTLE for information about good research-based practices around mental health. So we really want to use strategies that we know work with these individuals. So those are just a couple of resources that we call upon. So always, we want to make sure that we're teaching alternative skills. And the idea is to make those replacement behaviors as efficient and as effective as the problem behavior. So for example, if we know that there is a link between communication and behavior, and so we give the individual a communication device, but we don't ever listen to the individual using their communication device, we don't ever pay attention to it. We may have given them that communication device, but that communication device is not going to be an efficient or effective replacement for their problem behavior. We have to make sure that whatever we choose to do, that we really acknowledge that as the replacement behavior. So some alternative skills that we want to teach are problem-solving skills, choice-making ability, anger management, relaxation, self-management and self-control, again, communication. And I will tell you as a professional, and I tell this to our parent groups and I tell these to our professionals, if I were the parent of a child with autism and my child was getting speech therapy only once a week for 30 minutes, I would be livid. If they were getting speech therapy services twice a week for 30 minutes, I would be angry beyond belief. 3 times a week for 30 minutes, I would still be livid. And I think the point is that we don't understand that communication is not about the number of minutes of speech language therapy, although our SLPs are critical in that process. It really is a question about how does this child communicate at all points during the day? And that means that that's the responsibility of everybody in that child's life, using those communication devices, enhancing communication, making sure to sabotage things a little bit so that the child communicates and that we're not anticipating their every need. Social skills, and that's one of those things that we need to be continually coaching our folks on. That's a great example of taking advantage of those teachable moments. Learning social skills is very difficult. And the reality of it is I don't know about you all, but I make social skills mistakes all the time. And for our folks on the spectrum who do not read facial expressions or body language and understand when people are upset, you're going to see that oftentimes they make mistakes. Then resilience and grit, I just have to keep putting that in there because we know both of those things. If you look at the long-term success of people with disabilities, those are critical. And then emotional and self-regulation as well. So ultimately, our job, I think, is about creating stories. And my staff and I like to sit around and tell stories about kids' lives. I'm so blessed and honored to do what I do. And, you know, we have funny stories, we have sad stories, but we love to tell stories. And it really is about making long-term change. You know, really, again, the success of what we do is if we see one of our students at the age of 25 and they're having a good life, I feel like we've been successful. So looking at long-term prevention, you know, there's really permanent supports that we put into place to really maintain that desired behavior. And those include quality of life things, looking at health and well-being, looking at getting them to have increased participation in their community, teaching individuals how to make choices. And that's really important. We can start that from a very young age and for them to have more control in their lives. So what you will see is that, again, increasing those connections for our individuals is really important. So long-term prevention, we also want to identify supports in the community. And again, the systems of care, and make sure that families are connected with the long-term supports they're going to need. You know, for us, this is just a sprint. For our families, this is a marathon, okay? And the other piece of this is that we're also going to have to change. You know, behavior is a dance, and we're part of that dance. And I think as a teacher, probably the hardest questions that I had to ask were about what my role was in terms of the behavior. And so, you know, we're going to have to assess our own reactions and responses to behaviors. And really the goal is to really make the problem behavior less relevant, less efficient, and less effective. And whatever we do has to be implemented systematically. So I've kind of talked to you a little bit about this young man. This was a young man who I got to see who was kind of like a younger version of Sheldon Cooper. And he taught me many lessons. He was a child who had a co-occurring mental health issue and ASD. And some of the lessons that I learned from him, first of all, is that you have to know a child's entire life. You know, as I was working with him, I started asking questions about his life and found out that, you know, he hadn't seen his mom for a long time for a number of reasons, and that he was living in a situation that wasn't the greatest, and that, you know, to understand the child's whole life, that kids come to us as 24/7 kids. And they bring, when they enter the schoolroom doors, they don't leave behind all those things. And again, that there's many things you don't have any control over. Know what you have influence over. The other thing is that every child needs a champion. And when I got to know this young man, he was pretty smart. Educator did not like him, I'll be honest with you, and was pretty verbal about it. And as I spent time with him, at one point, I went up to him and I said, you know, you really are a remarkable young man. And I said, I bet people tell you that all the time. And he said, no, no one's ever told me that. And I hate to say this, but I have had multiple individuals on the spectrum who have told me the same thing, that nobody's ever told them anything positive about themselves. And so with him, I sat down and got out a piece of paper and we started jotting down what I saw, and what he saw were positive qualities. And I had to really coax him to come up with those positive qualities. And I shared them with others, and I said, I want you to read these now and again and understand how wonderful you are, you know? And I think when I'm working with, whether it's adults or children, I think all of us need a champion in our corner who are going to be the people who stick up for us, who understand us, who can kind of help us navigate the system, you know? And so for him, part of his programming was to find a champion. The other part of that was to find areas during the day where he felt successful. He was really good at math. And so he was able to explain math to other kids who did not do math as well. And because he really was very kind about working with other kids, it was a perfect thing for him to do. And I think the other thing that is the reality is that things that work with these children oftentimes work with children with mental health issues as well. As I've been getting into this, I have not found that there's two discrete literature bases around what works with one and what works around the other. I'll give you a couple examples of that in a little bit, but you know, if we look at universal design and if we talk about tiers of strategies, you know, these are kids, you know, all kids should have tier 1 approaches in place for all kids all the time in all classes, and knowing that we have tier 2 and tier 3 when problems start to escalate for kids. So develop a program that's based on their strengths and interests. Make sure you understand those strengths and interests and really build upon them. Temple Grandin is a friend of mine. We've been friends for a lot of years. Her career was based on her strengths and interests. She did not build a career based on deficits and limitations and things that she hated, you know? So, and I think it's a challenge to each of us that every day, every child we touch needs to feel some success, you know? That's a challenge. And we need to find out who they connect most with and use that person. And sometimes our kids connect most with the janitor or with the cafeteria lady, but who is it they connect with? Who's going to be a champion for them? And then when during the day are they the most successful, and how do we use that time to teach some alternative skills for them? So what do we do? Support, but do not overly support, you know? And, you know, a lot of our kids will have paraprofessionals, and this is not a statement that every child needs a paraprofessional. This is not a statement about that no child needs one. This is a statement that says that's a case conference decision. But I know that sometimes when we have paraprofessionals who are Velcroed to kids, that they develop a learned helplessness and a dependency, and that does not build resilience for them. Or we always let them be first in line, or we always let them win games. That does not build resilience for them. So we really have to balance out that accommodation and assimilation, realizing all of us need accommodations at different times. I think also giving them meaningful work. And, you know, one of the things that, a question that I will ask audiences when I actually have people in front of me is that I will ask people how many of them use and remember 100% of what they learned in high school. And just so you know, I've never had a hand raise. And then I go down to 75%, still no hands raising, 50%, a couple people raise their hands. And then, you know, I make a comment and I say, how many of you remember high school? You know, it was the 70s for me, so I barely remember it. But what I know is that, and some of you have probably taken college courses for which you had no need. And so what I know about all of us is that there are things that we do, courses we take, work that we do, and not that it holds meaning for us, but we have the ability to have delayed gratification. And we know that if we do that work or we do that activity, that it will lead to something meaningful for us. It will lead to a higher salary. It will lead to new opportunities. But for a lot of our kids, and not just kids on the spectrum, just kids with disabilities, but for a lot of our kids, they do not have the ability to have that delayed gratification. And so if they don't understand the meaning behind the work, and I know that's very difficult in this time where we have a heavy emphasis on testing and such, but I think we really have to think about how things relate to a child's life. Know how they learn best. And again, you know, our kids need a lot of repetition and they need visuals and stuff. We need to build in choice, teaching choice. Not everything is a choice, but we have to make sure that we teach kids how to make choices. I will tell you, sitting here at a campus that is, you know, 48,000 students, when students come back to campus, whatever that is, I see a lot of students who have not been taught how to make good choices. But being able to make good choices and knowing what choices you really have that you can make is really important in life. Be present. And so we talk about that proximity control and instructional control. One of the things that I think about is that we just have to be present with kids. So when I walk into a classroom and I see paraprofessional staff sitting all together and the teacher sitting behind their desk, we're not being present with kids. We have to interact with kids and be present and move around with them and engage with them. And the more present we are with kids, the more impact we can have on children's life, you know. And so I think that's one of the most important things that we can do with children is to be present. We want to look at maybe creating a community of support, connecting students via lunch bunches and other means. You know, we have done things with Bring Change to Mind, with creating mental health stigma clubs. So giving kids a place where they feel like they belong, having technology clubs, because a lot of our kids are really good with technology, connecting them with a friend or a peer mentor is really important, but helping kids have a community of support. To me, it was interesting when I started getting into the field of mental health. The mental health professionals told me, we really feel like our folks with mental health issues need to have some sensory needs. And so we're really going to encourage that classrooms have fidgets. Well, for those of us in the field of autism, we've been doing that for a lot of years. And so, and in our work in Indiana, we've also always talked about how you take these practices. We go in through the door of autism and we scale these practices up school-wide. So in a lot of our schools, they have fidgets for kids, and they have calming rooms for kids, or safe rooms where kids can go when they need a break. I mean, we all have our fidgets that we use. This is my fidget, So, and I think, again, that we have to make sure that our teaching is intentional, it's purposeful, and it's proactive, that we just don't say that we want a child to learn how to do this, and we leave it up to chance for them to learn it, because these are kids who are not going to learn by observing others. They need to be very intentionally taught how to do things. We utilize behavioral momentum. And so behavioral momentum is that when you want a child to do something new or harder, you have them do 2 or 3 things that are easy tasks to do. And then you introduce the task that is more difficult, but with support. We do a lot of task analysis with kids and to understand, for example, how difficult and complex something is. Like going into the school cafeteria may seem like an easy thing to you, but for our kids on the spectrum, it involves a lot of different steps. And we may have to figure out a lot how to teach them all of those steps, or figure out how to teach to the steps that they absolutely don't have, or to provide accommodations for those. We do a lot of visual supports. We know that 70% of us, all of us, are visual learners. We have free visual supports on our website that you can download and use. And I am very much of a visual learner. It's why I've got the PowerPoint on this presentation, is because I'm assuming some of you are as well. So visual supports, if you want me to read a letter, don't read it to me, let me read it myself. I make lists to make lists, and that's how I know that I'm supposed to be here today. And so if we do a lot of verbal with kids, it actually doesn't help them process. They may need some more visual supports. We also need to make sure that the rules, routines, and expectations are really clear. And if we develop rules, that they are operationally defined and that they are followed by all of us, and that they're taught as well, Likewise, if there's schedules that are being placed up, that we follow the schedule. I can't tell you the number of times I've gone into classrooms and I see a schedule on a board, and then I see what's going on in the classroom, and there's a disconnect between the two. Again, remember, for our folks with autism and with mental health, we're really focused on reducing their anxiety and helping to calm them. Students learn best in a calm and safe and predictable environment. So we do that by doing things like schedules and routines. We know that when routines are available, that it really helps students to deal with situations that are a little bit more difficult. And then we want to also make sure that we provide some clear transitions for folks. And in the mental health literature and the neuroscience literature, they talk a lot about brain intervals or brain breaks and building in movement. And so with my guy that I told you about, we started doing yoga, and he started teaching his classmates about yoga. So we try to build in movement very proactively into the day, looking at the schedule and seeing where those difficult times are to get kids up and moving around a little bit. And then building in a reinforcement system that really acknowledges the function or purpose of the behavior, that acknowledges what the payoff is for the behavior, and helps to encourage and enhance the behavior from happening. But if I was going to tell you one thing that I think is really critical, that is key to working with students on the spectrum, is key to working with any child, it's the rapport and relationship that we build with them. If kids trust us, if they have that rapport with us, they are more willing to try things. Likewise, the families that we interact with, if they have a rapport and relationship with us and have that trust, they are more willing and able to work with us too. They are giving us their most precious commodity, their child, and they need to trust that we're going to take care. So we build rapport in a lot of different ways. How the literature talks about it and our research-based approaches is that your positives should outweigh your negatives. And I've heard different criteria from 8 to 1 to 7 to 1 to 5 to 1. And this is true whether you're in special education, general education, or you're in organizations or businesses. You know, you want to make sure that you're doing more of you're doing a good job redirecting people than telling them what they're doing wrong. You know, our kids need to hear a lot of positives. And you know, one of the things that we're talking about as kids come back to the school year after this pandemic, part of the beauty of the school year may just be about rapport and relationship building and helping kids feel safe at first. And, you know, that will be really key for these kids who have been through a pretty unusual situation. But that rapport building, and, you know, if kids know they like you, that you like them, they're going to do more for you. If you don't like them, they're going to sense that, and you have very little hope of being successful. So school-wide systems in place, you know, we want to make sure many of our schools in Indiana have social emotional learning and mental health coordinators. Through the Indiana School Mental Health Initiative, it is something that we have really encouraged our schools to do, and we've networked with them. In our state, we also use the multi-tier systems of support model and really look at making sure that we follow that tier approach. We don't talk about tier 1 and tier 2 and tier 3 kids. We talk about tiers of intervention, because you know that a kid can be a tier 1 at one moment and tier 3 the next. So we talk about the tiers of approach that should be in place, and tier 1 being used all the time. In Indiana, we've also created high school clubs. We've worked with Bring Change to Mind, which is an organization out of California that was started by Glenn Close. So we have clubs that kids can belong to, so that they have a place they can go to talk about issues, and that we can kind of help with dealing with the stigma of mental health. It becomes a safe place. We, in our state, and I know many states have social emotional learning competencies or standards. And so, you know, it's balancing academics with social emotional learning. We know that many of our superintendents realize that in order for a child to be successful academically, that they have to be socially, emotionally healthy. And so there is a balancing of making sure that they're addressing all aspects of that. And we talked about the tiers, and that we use tier 1 all the time. So these are for all the students at all times. And I'm sure you guys have all seen the pyramids, because we're good at, we're popular for using those in education. So again, the tier 3s are really for those kids who have some really intense behaviors, and that's when you're getting into really problematic situations. And you do need to have some strategies. I actually like to go to PBIS World for some of these strategies. It's a website, really wonderful website, PBIS World. So in Indiana, we're still grappling with a number of things. Believe me, we don't have it figured out. We're still grappling with community mental health supports. Again, this initiative, the Indiana School Mental Health Initiative, started because our community mental health centers were not taking kids with autism in. Once they saw that they also had a diagnosis of autism, they would turn them away. And at that time, we were told it was because of funding and it was because of expertise. And so we've worked with our state to try to deal with the funding issue. But I think that still, we're still, and many of our community mental health providers are trying to get educated about working with children with autism. So we know that we have a long way to go in terms of capacity building there. And that really was where the Indiana School Mental Health Initiative was really out of that desire to start out with working with kids who had co-occurring mental health and a developmental disability, that our community mental health centers would see them. And I see some of our mental health centers are stepping up to that. But we've also taken on a whole new dynamic where we're looking at kind of the needs of the general education community as well. But, you know, for families, it's very difficult when services are siloed. You know, our kids don't fit into these kind of neat little boxes of, you know, they oftentimes have issues and service needs that cut across services. And so that's one of the nice things about a model like Systems of Care, is that we start looking at how to pull these services together in a more seamless way. We're still grappling with enough psychiatrists. And we have, I'm happy to say that our IU School of Medicine this year is filled, their cadre for psychiatrists is filled, but I know that we still have many more needs. And I'm understanding that Psychiatrists, can oftentimes find great jobs in other states, so they can jump around some. So we're always looking for psychiatrists who can address the needs of kids with autism. On our website, we put together a list of people who diagnose and assess autism. And some of those are also counselors, and some of them are also people who will do medication management. So we try to give families resources so that they know what they know where to go. I will not lie to you, it is harder in rural areas of the state of Indiana, and Indiana has a lot of rural areas. So finding services for all families in all areas of the state can be very challenging for our state. And likewise, the diversity of our state, finding those that can deal with the various kinds of diversity that we have in our state, whether it's racial or socioeconomic or whatever is the diversity in our state is really important. We're still grappling with good crisis options. Again, I'm always a great supporter of, we need to keep kids in the least restrictive and less restrictive setting, keeping them in schools. But every once in a while, we have kids who need to go to someplace that is more restrictive. And that is not ideal. And I know that people get upset sometimes when I talk about this stuff, but it's just reality. And I live in reality because I'm in schools all the time, and I see some of these kids just are beyond what home and school can support. And we're grappling with finding good options. We know that in our state, and like many states, from what I hear, is that our direct service providers in those programs are often underpaid. And oftentimes there's a rotation of them coming through the programs. And when you put a lot of individuals together in one place who have a lot of difficulties, it's a challenge. We're still grappling with the need for school social workers and taking a more preventative approach. We have found that in our state, there's a tendency to want to take a reactive approach. And so when we had a school shooting, the concern was, as it should be, around school safety. So we've really had, I don't feel like it's an either or, it should be an and. It should be both that reactive approach and the preventative approach. But we've had people who have a hard time kind of moving themselves over to that proactive approach. We have a woeful low number of social workers per child in every district in our state. And so in terms of providing home school communications and home supports, it's very difficult for our social workers, and they are very stretched. Many of our school districts will form relationships with community mental health centers so that they can provide some of that needed support that schools can, because again, we know that schools can't do it all. So as part of this, we have to assess our own behavior, our own issues. I will tell you that I probably am not the norm in this. I don't believe I'm the norm at all, but I have dealt with kids who are really aggressive through the years, and I am less troubled by dealing with kids with aggressive behaviors. But if you give me a child who is whining, that is hard for me. It just is honest, And I think that we all have to talk about and understand our hot buttons. And I know that as a teacher, there were times that because of how I was feeling or what was going on, I was less tolerant of a behavior on a certain day. And so I had to know that and acknowledge that in myself, and either ask for more support from a colleague, or else just know that I had to kind of back off a little bit from the individual, because all of us bring something to the table. We all bring our own issues. And what we bring to the table is going to impact our responses and our ability to be consistent, So we've got to take better care of ourselves, and know what we have control over. And, maybe we need to look at the ACE score that we have as well. So I know for myself that I am timing myself out from watching the news. Watching too much news or too much around the social networking is really takes me down. Because like all of you, I want to know that there's an end in sight, and I don't see it. And so in these days, really reduce that access to the news. If you can meditate or just spend some quiet time without any noise going on around, healthy eating, Exercise. I have made a point that every day on my to-do list, I go take a walk. And on those days where it's rainy, I have exercises that I do at home, but I'm really actively pursuing making sure that I don't come out of this all with not only compassion fatigue, but also Zoom fatigue as well. Connect socially with family and friends, know where your support comes from. I know my family connects a lot via Zoom because we have members around the country. This weekend, we had a virtual birthday party for one of my little cousins where everybody was baking cupcakes virtually and then saying happy birthday to her. So know where your support is from and really do not hesitate to reach out. I think we all have to give each other permission to say when we've had enough, when we need a little bit more support. And that's one of the things I'm very blessed with the institute that I work at, is that we are being really honest with each other about when we need support and lending a hand to pull our colleagues up when we need that support. I think it's also important to be around positive people, and don't forget about laughter. Laughter is very medicinal. I try to laugh every day. And I'm trying to stay in wellness and gratitude, but it's hard sometimes, but for me, I know that there are some people that when I'm around them, it pulls me up, and other people, it pulls me down. And so I'm trying to be around positive people as much as possible. We also know from the mental health work that individuals do best when they feel purpose. And so I have set goals for myself and for my staff to think about what our purpose is. Our purpose has shifted a little bit, but how do we establish a new purpose? And how do we establish routines so that we can see that we're actually achieving something towards those purposes or goals? So I think the bottom line is all of us, and during this time, all of us need to experience success, and all of us need a champion in our corner. And I know for our kids, as they're coming out of this, they're going to need to experience success, and they're all going to need champions in their corners as well. So identify a person they can connect to in the school. Who's going to be that champion for the child. There's a practice that's done in some schools where they put the names of every student up on a wall, just on little Post-it notes. And then they have staff go around and put a check mark by the students that they connect to. And then they stand back and look to see what students no one's connecting to, and then they figure out how to connect to that student, because all kids need to make sure that there's a connection. I want to thank you for the opportunity to do this webinar, and I hope that you are all well, and take care of yourselves. Thank you.